Good afternoon, and thank you for joining us today for All Hands on Deck, Indiana's comprehensive STD Preparedness Plan, hosted by HCET with presenters Emily Fussell, Jeremy Musko, and Madison Hensley. My name is Jess Steinbarger. I'm a training manager at HCET, and I will be moderating the webinar today. Let me briefly introduce you to healthcare education and training. HCET's mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes. HCET is an organization of passionate people who are proactive in their belief that access to evidence-based, medically accurate reproductive and sexual health education, training, and care is a fundamental right. For more information, and to keep up to date with HCET events, please be sure to follow HCET on these various social media platforms and visit our website. Now I will quickly review some housekeeping information. A link to complete an event evaluation will be sent to you via email following this webinar. Your feedback is greatly appreciated. Archived presentations and a list of upcoming events can be viewed on our website. If you have any technical difficulties during this presentation, please contact HCET at the phone number listed on your screen. Throughout the presentation, we encourage you to send your questions via the chat box. To submit a question, hover over the main screen, then select the chat icon. Once selected, the chat box should appear on the right side of your screen. To send a question at any time during the presentation, please send it to all panelists. This ensures everyone behind the scenes can view your questions. We will hold all questions until the Q&A portion of this presentation. Now I'd like to quickly introduce you to your presenters for today. Emily Fussell is a graduate of University of Evansville with a Bachelor's of Science in Public Health. Emily has been working with ISDH since 2017. She began working as a disease intervention specialist in the Lafayette, Indiana region and quickly progressed into program management. Emily now serves Hoosiers at the state level as an STD prevention program specialist in the state's division of HIV, STD, and viral hepatitis. Jeremy Musko graduated from IUPUI with a Bachelor's of Fine Arts in Painting and a minor in Psychology. Jeremy started his career in public health as an HIV case manager and then became Quality Management Director at Step Up, Inc., a nonprofit organization that does HIV testing and outreach. Jeremy has since moved into program management as an STD prevention program specialist in the Indiana State's Division of HIV, STD, and viral hepatitis. Finally, Madison Hensley is a program specialist for the STD division at ISDH. Madison graduated with a bachelor's degree from Indiana University. She worked with IU's health department in sexual health outreach and prevention as part of her time in her undergraduate career. Madison also worked with Mental Health America before onboarding at ISDH. Without further ado, I'll be turning things over to Madison. Thank you.
Good afternoon. So kind of going in, we're going to be reviewing an STD Preparedness Plan that was created here at the state level. Part of this plan, we're going to be reviewing preparation for an emergent STD situation, activation of the preparedness plan, management of the plan, and recovery after the situation. Next. So today, as I said, we're going to be giving a broad overview of the steps taken for the preparedness plan. The state and county will use an incident command system when an emergency situation takes place. An emergency situation will be determined by the state health department. The majority of this work is going to be completed by disease intervention specialists as well as other related staff at the county level, and the state will be assisting as needed. Next. This plan will specifically cover chlamydia, non-resistant gonorrhea, and syphilis. Antibiotic-resistant gonorrhea is not included because a plan was created by them by the Surge Epidemiology Coordinator. Surge is the Strengthening the U.S. Response to Resistant Gonorrhea program here at the state. Next. Here you can see some of the main people involved in this preparedness plan. At the state level, you may have the STD Program Director, Operations Manager, Epidemiologist, Health Advisors, as well as State DIS. Going higher up into the Indiana State Health Department leadership, you may have the State Health Commissioner, Deputy State Epidemiologist, Office of Public Affairs Director. And then at the local level, you'll have clinicians, disease intervention specialists, medical directors and health officers, communications liaisons, and communicable disease coordinators. Next. As you can see, here is a map of the state. So the way the state works is it is split into districts. There is a total of 11 throughout the state. In each district, there is a certain number of counties. There might be more counties in some districts than others. Local DIS are located in health departments, health centers, and private medical facilities in their district. For example, in District 1 in the top left corner, the disease intervention specialists are located at the Gary Health Department. There is roughly a total of 40 DIS all throughout the state. We also have different levels of DIS. This may determine what kinds of cases they may be working. An important note to mention is that local DIS are required to stay within their district. Because of this, the state has hired state DIS. There are 5 in the state. These state DIS are employed by the state and have the ability to travel all over the state when needed. Next. Something to know for when you're looking at an emergent situation is case definitions. They're important because they're able to define what is a case consistently across reporting jurisdictions. The definitions used are created from the Council of State and Territorial Epidemiologists. During an emergent situation, the state would take these definitions, modify them, and add to them since they will be changed in an emergent situation. You can see that there are links that you can go to find those definitions. Next.
Hi, this is Emily Fussell. I am the STD Prevention Program Specialist with ISDH, and I will be discussing with you today how we prepare for the emergent STD situation. Next. So preparation is prevention. Prevention is a key pillar of public health. We consider preparation to be one of the best tools we have against emergent STD situations. So how would Indiana prepare? We have specialized DIS training in which we train our DIS in case investigation techniques and fieldwork techniques and motivational interviewing techniques. We also have constant epidemiological analysis to identify new trends. We have policies and procedures and policy and procedure improvement for DIS to enhance their casework. We also have STD and HIV testing services funded by STD and HIV prevention programs. We have the Chlamydia and Gonorrhea screening program. In addition, we have a partnership with Outreach Supplies. Next. So in the state of Indiana, we use the syphilis alert system to monitor STDs. This is going to be a high-level overview of our mechanisms for tracking case counts and comparing epidemiological data. I wanted to get a definition out of the way. When you hear me say mean number, for those of you who are unsure what mean number means, we're referring to the average number of case counts in this instance. The syphilis alert system is a combination of the SAS database and Excel to produce a spreadsheet that enables monitoring of case counts. It will calculate the mean number of primary, secondary, and early latent syphilis cases over a period of 18 months. Then, with this information, the STD epidemiologist compares the baseline, or the expected number of monthly cases, to the current number of cases to determine if there has been a significant increase in case count. Next. So a little bit more information on the syphilis alert system and how this works. another definition I wanted to get out of the way for those of you who may be unsure of some of these epidemiological terms. Standard deviation is a measure of the amount of variation in a set of values. So in this instance, a low standard deviation would indicate that the values tend to be closer to the mean number, and a high standard deviation would indicate that the values are spread out over a wider range. In the context of the alert system, the mean number would reflect case counts, so the standard deviations will reflect a value above or below the mean. More information about how we use this spreadsheet in an emergent situation will be covered later in the presentation. In addition, we will also cover the steps and actions that the STD prevention program will take once triggers occur. One standard deviation above the mean in the syphilis alert system would create a warning indicator in the spreadsheet. 2 standard deviations above the mean creates a rapid response trigger in the syphilis alert system. The spreadsheet will also calculate the increase of cases from the previous year to the present time for each county within the district. It will also graph yearly cases by district, and it summarizes the changes that have occurred between the previous report and the most current report. We also monitor chlamydia and gonorrhea using the spreadsheet with the same epidemiological mechanisms that I previously described to you. Next.
All right. Hi, my name is Jeremy Musko, and today I will be discussing with you partnerships, specifically the chlamydia and gonorrhea screening program. In addition, I will also be discussing with you supplies and medications needed to respond to an emergent chlamydia or non-resistant gonorrhea situation. Next. All right, so objectives, we are going to cover the basic function, structure, and process of the CTGC program, how the CTGC program can be utilized in an emergent STD situation, what supplies are used to screen for chlamydia and gonorrhea, what medications can be used to treat chlamydia and gonorrhea, and then also how to prepare for testing in the field for chlamydia and gonorrhea. Next. This is a high-level overview of the screening program. The screening program, it is a statewide program that assists local agencies in providing little to no cost chlamydia and gonorrhea screening and treatment to individuals in their community. It's funded by the STD Prevention Program through CDC federal grants. It is a collaboration between the STD Prevention Program, the Indiana State Department of Health laboratories, or ISDH labs, and local participating agencies such as county health departments, Title X clinics, and crisis pregnancy centers. One thing that I will note here is that all DIS sites participate in the CTGC screening program. So what does the program do? We provide specimen collection supplies. ISDH Labs provides them to screening sites. And then the STD Prevention Program provides participating agencies with state-supplied STD medications through the 340B drug pricing program at competitive public health prices. Next. Across the state, we have over 50 screening sites. One thing I will mention is that this map is a little outdated. We're working on updating it. You can find this map on the ISDH website, in the STD Prevention Program website. It's an interactive map that will show you all screening and full service clinics. Screening clinics do not have a clinician on staff. They are represented in blue. So they may not be able to provide immediate treatment and may restrict services based on residency or sex. The purple pins shown are full service clinics, so they will have a clinician on staff, so would be able to provide immediate treatment. They also might provide additional STD testing, such as herpes, trichomoniasis, and vaginosis. Next. All right. So now we're going to talk a little bit more about the 340B drug pricing program. It's a federal program that requires drug manufacturers participating in the Medicaid program to provide certain outpatient medications to eligible healthcare entities at reduced cost. The intent of the program is to allow certain entities to stretch scarce federal resources as far as possible to provide more care to patients. This program allows STD programs to buy these medications and provide them to DIS and CTGC screening sites at no cost. All CTGC screening sites enroll and recertify and have to comply with a 340B program in order to receive state-supplied STD medications. All right. So the screening program, because it's funded by the STD program, is built to reach the most at-risk populations for STD testing services. During normal operations, the program does this by targeting at-risk patients through our program screening criteria. The program will cover the cost of the tests for eligible patients or those patients that meet the screening program criteria, and the program will not cover the cost for those patients that do not meet the screening program criteria. Those patients would need to cover the cost of the test, which is $20. In an emergent STD situation, the program would change a little bit. In an emergent STD situation, the STD prevention program would reach out to sites in the affected areas and discuss how they could best assist with the emergent situation based on their current resources and capacity. This would, sites in the affected area may target those at risk, The program screening criteria might change a little bit for the sites in the affected area because of the emergent situation. So we would provide them with additional guidelines of people who may need to be tested based on what's happening. The agency would also continue to screen the general population in accordance with the normal program screening criteria. In an emergent situation, the STD program would cover the cost of tests for anyone who falls outside of the normal program screening criteria during the course of the emergent situation. In addition, the STD prevention program would work closely with those CTG sites in the affected area to ensure that they have the necessary supplies and medications. Next. Okay. So this is the program's screening eligibility criteria. The patient must be without health insurance or underinsured, meaning that they cannot pay for the test, they cannot receive the service due to high co-payments or unmet deductibles. In addition, the patient must also meet one of the 9 criteria listed below. So this could be if the individual is under age 30, if the individual is a sex partner of a person with a chlamydia or gonorrhea infection, regardless of age, men who have sex with men of any age, persons with symptoms suggestive of chlamydia or gonorrhea, and so forth. One thing that I will mention here is that test of cures, if an agency treats a patient with an alternative treatment regimen, they should complete a test of cure within 14 days after the medication was given to ensure that the patient, that the medication worked correctly. And that's just with alternative treatments. And then also retests are for those who have had positive tests in the past 6 months to make sure that reinfection has not occurred. So in an emergent STD situation, these criteria may change based on the epidemiological information available about the emergent situation that is occurring. And the STD prevention program would communicate this to participating agencies. Next. Okay. Sites request and receive so how the program works. Sites request and receive specimen collection kits and state-supplied medications through the program. Staff at sites screen patients to determine program eligibility, and also a sexual health history to determine risk factors to make sure that they meet screening criteria. The patient self-collects specimens at all anatomical sites as indicated by the patient's reported activities and risk factors. Staff input the patient information and specimen information into LintNet, ISDH Lab's electronic specimen submission database, and then ship the specimens to ISDH Lab through UPS Campus Ship. Staff at sites monitor LintNet on a daily basis to check for specimen results. Next. When a patient receives a positive test result, the staff at the site notify the client, set an appointment for treatment if the patient was not empirically treated on the first visit. Staff treat the client using the state-supplied medication in accordance with CDC treatment guidelines and the 340B drug pricing program criteria. Staff will also review risk reduction practices and provide partner services. Staff also encourage the patient to be retested in 3 months to check for reinfection. Staff will also complete an STD communicable disease report and send it to their local DIS site. To report an STD, there are 2 links. You can do it through the web, through the link provided, and then also there is a paper form that you can fill out. Next. So I also just want to give a little bit of an overview about what partner services is. So sites will provide partner services to patients with positive test results. We call these patients original patients. The purpose of partner services is to identify individuals exposed to the infection, or contacts as we call them. So we want to notify the contacts of their exposure, and then refer the contacts to screening services to stop the spread of infection. One thing that I will mention is that partner services must be confidential and private. When notifying a contact, we must ensure the confidentiality of the original patient's identity in relation to their contacts. And then when notifying a contact, we also must ensure their privacy in relation to others, such as family, friends, in the instance of when we give them a call, or send, mostly we would just be either sending a referral letter or giving them a call. So confidentiality and privacy are very important. Next. Okay. So partner elicitation will also be provided through partner services. So staff identify the contacts, the patient's contacts through guided discussion. So this would be all sex partners in the last 60 days from the date of treatment. If the patient does not report any sex partners during that time frame, then the last sex partner, the information regarding the last sex partner would be elicited. And then we would notify and refer the partners. This can be done in a number of ways. The original patient can bring their sex partners or contacts with them to their appointment. A referral letter could be mailed to the contact. We could notify the contact through phone. Expedited partner therapy could also be implemented. And if all of these were still unable to reach the client, we would refer it to the contact to a DIS agency. Next. Okay, so in an emergent STD situation, one thing that we would need CTGC sites to do is assist DIS and allow DIS to use them as a resource to accommodate increased testing for chlamydia and gonorrhea, and also treatment. In an emergent situation, the GC screening program coordinator, myself, would be responsible for notifying the labs of increased utilization of specimen collection supplies, as well as the labs receiving increased specimens, notifying our medication warehouse of increased utilization of state-supplied STD medication, and communicating and working with the participating agencies to make sure that they're aware and prepared for the increased utilization of services. Next. All right. So these are the these supplies can be ordered in LIMSnet by sites that are participating in the CTGC program. We have the unisex swab for anal specimens, vaginal swab for that can be used for females. And as far as when you see the word female only, we're referring to those individuals who have a vagina. And when you see male only, we're only referring to those individuals that have a penis. And this is because specimen collection kits are site-specific, and we really want to capture the disease where it's at in the body. Unfortunately, at this time, ISDH Labs does not accept pharyngeal samples. And furthermore, the program does not permit female urine and male urethral specimens to be taken. Next. These shipping supplies can be ordered in LIMSnet by sites that are participating in the CTGC program, which are mailing envelopes, UN 3373 address labels, and mailing cans. Next. Similar to the program screening criteria, the state-supplied STD medication also has its own eligibility criteria. CTGC sites must ensure patients are eligible for state-supplied medication through the program through this criteria. In an emergent situation, the criteria may change just based on the nature of the emergent situation. And the STD prevention program would notify those sites affected by the emergent situation of any changes to the eligibility criteria. Similar to the screening criteria, the patient must be without health insurance or underinsured and must meet one of the following criteria listed below, which are lab-confirmed chlamydia and gonorrhea or infectious syphilis test. Of course, in terms of chlamydia and gonorrhea screening sites, they would need to work with disease intervention specialists in order to treat the patient for syphilis. So those persons with lab-confirmed tests, persons with lab-confirmed tests who were tested by a community medical provider and who lack the means to access care or treatment through these providers. Those sex partners within the last 60 days to a lab-confirmed case of gonorrhea or chlamydia. This also includes expedited partner therapy. And then the last one doesn't really pertain to the current situation. Next. Okay. So the STD prevention program provides the following medication for chlamydia and gonorrhea, and that would be azithromycin, ceftriaxone, doxycycline, cefixime or Suprax, and gentamicin. One thing I want to note about gentamicin is that it is only available after consultation with the surge epidemiology coordinator and would be ordered directly through the STD director. And then the program also offers syphilis, offers Bicillin LA or penicillin G to treat syphilis. This is only provided to disease intervention sites only. In the case of an emergent STD situation, chlamydia and gonorrhea screening sites would work with DIS sites to provide treatment for syphilis if it was indicated, and this would have to go through the program director before it would be allowed to be completed. Next. Okay. So these are the CDC treatment guidelines for chlamydia. The recommended treatment regimen is azithromycin 1 gram orally in a single dose. I also want to point out the alternative treatment regimens on the right side of the screen. If a site is using an alternative treatment regimen, they would want to perform a test of cure on that patient within 14 days to ensure that the infection was treated appropriately. Next. Okay, so this is the CDC treatment guidelines for gonorrhea. The recommended treatment regimen, of course, is ceftriaxone, 250 milligrams intramuscularly in a single dose, with azithromycin 1 gram orally in a single dose. These medications need to be administered together as per CDC guidelines in order to combat resistance. Below that, you also see the recommended treatment regimen for uncomplicated pharyngeal gonorrhea. On the right side, you'll also see the alternative treatment regimens. Two things I want to point out. One being, if ceftriaxone is not available, then you can use cefixime or Suprax as an alternative treatment, 400 milligram orally in a single dose, also with the azithromycin 1 gram orally in a single dose. If the patient has a verified cephalosporin allergy, you can use, they have two alternative treatment regimens. Gemafloxacin is very hard to obtain, so the best bet would be gentamicin 240 milligrams intramuscularly, single dose, plus azithromycin 2 grams orally in a single dose. For an alternative treatment for pharyngeal gonorrhea, you'll want to refer to the CDC treatment guidelines. Next. On this slide, we have recommended and treatment regimen for pregnancy. What I mostly want to draw your attention to is disseminated gonorrhea. We are seeing an increase of disseminated gonorrhea in the northern part of Indiana, so it's important that clinicians are aware of the treatment for disseminated gonorrhea infection. We also ask that agencies notify the STD prevention program immediately and collect and process NAT or culture specimens from urogenital sites, as well as site of the disseminated gonococcal infection via blood culture or through synovial fluids. And then you will want to refer to the most updated CDC treatment guidelines for complete treatment information regarding disseminated gonorrhea. Next. Okay. While local health department staff do not usually go out into the field to conduct testing, it could be beneficial to keep these supplies on hand in order to facilitate testing. So some sites might want to have a field screening bag on hand. This would contain specimen collection supplies, risk reduction supplies, referral supplies, as well as pen and paper. One thing I want to point out is to remember to process all specimens as soon as possible. Urine specimens must be submitted within 30 days, and swab specimens must be submitted within 60 days. You'll also want to ensure that urine, vaginal, and rectal specimens are refrigerated or kept in a cool, dry place after collection until the specimen is sent. Next.
So moving forward, I'm going to talk to you about our partnership with Outreach Supplies, syphilis-specific supplies and medication, as well as the DIS response. Next. So what is Outreach Supply? Outreach Supply is a website that disease intervention specialists utilize for testing supplies, venipuncture supplies, campaign and marketing tools, handouts, safe sex kits, and event kits. The program also is able to utilize a graphic designer through this service for banners, infographics, and other educational material. Part of creating the preparedness plan, we also created emergency kits that can be ordered through the supply site. So when an emergent situation occurs, the emergency kit would be posted on the site and can be ordered to have all the necessary items for the DIS and other testing staff. These kits will also be available for non-DIS agencies. This is an example of what the page looks like. There will be different tabs you can click on to get to the different items. Next. The next few slides also might be just more examples of supplies and an example of what the page looks like. For example, this is our blood collection supplies, including cotton balls, butterfly needles, etc. Next. Our emergency kits are going to have a variety of testing supplies as well as instant HIV, rapid syphilis, or a quick hepatitis C kit. It also will include pens, Sharpies, memo pads to be able to mark and keep track of the collection of the specimens. You also have biohazard bags and hand sanitizer, paper towels, etc. Next. These are more specific specimen collection supplies, such as sterile cloth gauze, blood tubes, Band-Aids, straight needles, medical gloves. Next. As stated earlier by Jeremy, these are the shipping containers we use, in addition to the gonorrhea and chlamydia mailing kits. The lab can also provide the appropriate biological hazard mailing containers for syphilis, HIV, and hepatitis C blood specimens. They can be ordered specifically by DIS by requesting the specified containers to the email containers@isdh.in.gov. The cost of these containers is free of charge. Next. These are the CDC treatment guidelines for syphilis. Bicillin and doxycycline are purchased by the state at the 340B drug prices. In the event of emergent situation, their patients must meet a criteria to be treated with the state-supplied bicillin. You can see some examples here. For example, primary and secondary uncomplicated syphilis would be treated with bicillin or BIC 2.4 MU. An alternative to that might be doxycycline, 100 milligrams twice a day by mouth for 14 days. Some of them are going to be the same, and some are going to be different with different doses as well. Next. So an important part of treating someone with syphilis, if you're referring to someone who could possibly be pregnant, biological female patients must be know their pregnancy status prior to the administration of doxycycline. A patient will self-report their pregnancy and/or their last menstrual cycle. DIS can attempt to verify a negative test if they have the patient's provider. Some agencies even might be able to offer a pregnancy test to the patients on-site to verify their pregnancy status. Doxycycline is contraindicated for patients who are pregnant. Parenteral penicillin G is the only therapy with documented efficacy for syphilis during pregnancy. And pregnant women with syphilis in any stage who report a penicillin allergy should be desensitized under the care of an allergist or infectious diseases doctor and treated with penicillin. The selection of the appropriate penicillin is really important because T. pallidum can reside in sequestered sites, such as the central nervous system, that are poorly assessed by some forms of penicillin. Next. All right, next we will be talking about sexual contact to syphilis. So a person who has been exposed sexually to someone else who has primary, secondary, or early latent should be evaluated clinically and serologically and treated according to the following recommendations. Persons who have had sexual contact with a person who have received a diagnosis of primary, secondary, or early latent within 90 days preceding the diagnosis should be treated presumptively for early syphilis, even if serological test results are negative. In the event of STD situation, emergent situation, the prevention program would recommend notification and presumptive treatment of sex partners of persons staged as unknown or late syphilis who have high serological test titers. This could be greater than 1 to 32 because high titers are indicative of early syphilis. These partners should be managed as if the index case had early syphilis. Persons who have had sexual contact with a person who receives a diagnosis of primary, secondary, or early latent syphilis greater than 90 days before the diagnosis should be treated presumptively for early syphilis. If the serological tests are not immediately available and if the opportunity for follow-up is uncertain. If serological tests are negative, no treatment is needed. If serological tests are positive, treatment should be based on clinical and serologic evaluation and stage of syphilis. Long-term sex partners of persons who have unknown duration or late syphilis should be evaluated clinically and serologically for syphilis and treated on the basis of evaluation findings. The following sex partners of persons with syphilis are considered at risk for infection and should be confidentially notified of exposure and need for evaluation. Partners who have had sexual contact within 3 months plus duration of symptoms for persons who receive a diagnosis of primary syphilis, 6 months plus duration of symptoms for those with secondary syphilis, and 1 year for persons with early latent syphilis. Next. We'll now be getting more into understanding a state DIS response in an emergent STD situation. As we said earlier, state DIS can be deployed all over the state. They can be deployed as up to soon as 48 hours of notification to the county or site. State DIS will be utilized to deliver supplies, medication, as well as helping with testing with chlamydia, gonorrhea, syphilis, HIV, and hepatitis C. The state DIS are trained for field investigation and can seek patients for testing or treatment in locations other public health workers may not be able to go to. Next. State DIS also are able to help with training and education if needed. If they locate a training gap, they can help with that training as well as with the training DIS training coordinator from the state. State DIS also have relationships within the community, such as medical providers, housing and domestic violence shelters, food pantries, subsidized housing, and other local hotspots. These relationships can help target response efforts during an emergent situation. Next.
Okay, now that Maddie and Jeremy have told us about our partnerships and kind of the things that we would use during the response, I'm going to describe to you all how we actually declare the activation of the preparedness plan and how do we say, okay, we're experiencing a CTGC or a syphilis emergency. Next. The previously described syphilis alert system is run monthly by the STD epidemiologist. However, declaring an activation of the preparedness plan is not very cut and dry. There are several discussions and analysis to be conducted prior to declaring an activation. Generally speaking, an activation will only occur after 2 consecutive triggers. 2 consecutive triggers indicates there are 2 months where there are increases above the expected amount of cases. When we're dealing with chlamydia and non-resistant gonorrhea, it can be difficult to declare activation of the preparedness plan for either infection. With such a high incidence rate nationally, 540 cases per 100,000 population for chlamydia, and 179 cases per 100,000 population for non-resistant gonorrhea as of 2018, The definition of an STD situation may take on a meaning that's not usually associated with common preparedness responses. Indiana sees incident rates in these infections very similar to the national rate. In Indiana, we have 524 cases per 100,000 population for chlamydia and 183 cases per 100,000 population for non-resistant gonorrhea as of 2018. Taking this into account, the method that we use to monitor syphilis in Indiana cannot truly be applied to chlamydia and non-resistant gonorrhea. 1 or 2 standard deviations of the mean for chlamydia and non-resistant gonorrhea would show a case increase per year that could very easily be attributed to other public health factors, such as resistant disease or increased screening efforts. Next. The activation of chlamydia and non-resistant gonorrhea preparedness plan would be most useful if the change in case rate were detected over a period of time less than 1 year. To define a baseline of either infection would require a stable period, but because disease reporting, detection methods, and patterns of testing have varied over time, monitoring for triggers in the spreadsheet is likely best done in uniformly tested high-risk subpopulations. As I've stated before, declaring an activation involves a lot of discussion and analyzation. When 2 triggers appear in the spreadsheet, the STD program will engage in the following steps. The epidemiologist will conduct analysis for any new trends or trends within special populations. The epidemiologist and the assigned specialist who oversees the STD district will review the triggers in the spreadsheet and case counts of the district. The specialist will hold an in-depth discussion with the DIS and the area manager of the district to get a better understanding of what is actually occurring on the ground level. And the specialist will then report back to the epidemiologist and the STD director with their findings. And it is these findings of the specialist that will be the ultimate determining factor in whether or not the preparedness plan is activated. Next. When we consider syphilis, the same steps that I described in the previous slide will be followed. We will engage in careful discussion and analysis of the triggers in order to see what is actually happening. High and low morbidity will play a factor in regards to determining activation for syphilis. High and low morbidity in Indiana are defined by the STD epidemiologist. It is a comparison of incidents between the past year and the current year for a specific STD district. The STD epidemiologist will also methodically compare incidence rate in terms of specific populations between districts in order to help more clearly define high and low morbidity. High and low morbidity also help the STD program decide what next steps are taken in declaring an activation. Next. In regards to low morbidity districts, we have a more in-depth look at some of the other actions that will be taken when we declare an activation. These districts low morbidity districts may face more of a challenge when trying to mobilize resources to respond to an STD situation, and the STD program will offer guidance and support. When a low morbidity district in regards to syphilis experience 2 rapid responses in the alert system, we will evaluate the program's needs and any staffing concerns they may have. We will prepare to assign and send state DIS, if needed, to the district or county experiencing the situation. The STD epidemiologist will continue to monitor trends, and the STD prevention program will actively ensure that the DIS agency and the local health officer or medical director of the area receive all pertinent communications regarding the activation. We will also evaluate the need for increased testing and what other collaborations are needed at this time. When a low morbidity district experiences a rapid response trigger with a prior warning trigger or 2 warning triggers in the syphilis alert system, we will follow some similar steps as I stated above. We will also review cases more closely, and if needed, we will work with the local DIS of the district to see what is actually happening on the ground level. STD specialists will also pull data reports, and we will review cases to see if the triggers are centered in the district or if they're all connected to other cases in other districts. Next. In regards to high morbidity, in the state of Indiana, a high proportion of the disease burden is in the capital city, Indianapolis, and the surrounding donut counties. We call this District 5 for STD prevention purposes. And because District 5 has so much morbidity, the surveillance coordinator located at the Bellflower Clinic conducts weekly surveillance. The surveillance coordinator may be able to identify the need for the preparedness plan prior to the STD program epidemiologist. The STD program will support the high morbidity districts in the same way we support low morbidity districts, through careful discussion, analysis, and mobilizing resources or staff. At a more in-depth look at how we handle 2 rapid response triggers in the syphilis alert system for a high morbidity district, we will work together with the Bellflower Clinic staff and ISDH leadership to see if the increase is known and what all is happening with the increase. The STD program will offer to prepare and assign state DIS to District 5 if increased staffing is needed. And it is expected that the STD program and the Bellflower Clinic will ensure that Marion County's health officer is informed of the increase in cases. The STD program and the Bellflower Clinic will work together to identify if increased testing efforts are needed and what other collaborations are needed to address the increase of cases. Next. Once we've declared activation, we have to notify leadership. So now that we have determined the need for the preparedness plan, the STD epidemiologist and the STD director will work together to craft messaging of the activation. As previously mentioned, ISDH will follow the incident command system to handle an STD situation, as it offers a way to streamline communication and data sharing between many groups. Once we have declared an activation, the STD epidemiologist will notify leadership at the state and county levels within 24 hours of activation. At this time, the ISDH policy group will be established, and this would include the state health commissioner, the state epidemiologist, the deputy state epidemiologist, the division director of HIV and STD and viral hepatitis, as well as the STD program director. The initial command meeting will be convened by the state epidemiologist and will include ISDH policy group and the medical director of the local or the local health officer of the county or district where the activation has occurred. The initial meeting of leadership allows the policy group and the local staff to come to a consensus on priorities and a collective set of objectives. Next. In addition, we will establish the Joint Information Center, or the JIC. The JIC will consist of staff from the state and county levels and will include the Director of Public Affairs from ISDH and any appointed communication liaison at the county or district level. The JIC will also work with the STD Director to establish funding sources for the STD situation. Communication of the activation to the STD District will occur through the assigned STD specialist to preserve relationships and communication pathways. The STD specialist has a very personable and in-depth relationship with the district, and they would be the person who would be the best to deliver clear and concise messaging, as well as ensuring that relationships are preserved. Next. So as I've stated, we would follow the incident command system, and just to give you a little bit more in-depth view of the groups involved in the incident command system, as we said, the state epidemiologist will convene the initial meeting, and this establishes the command system at the state and local level, and the ISDH policy group oversees the response. The incident command team is divided into 4 main groups. We have communications, which assist in proofreading messaging, providing support to the JIC, and providing support for media messaging. The planning group will help schedule meetings, facilitate information sharing, and also assist in writing situation or SIT reports. The logistics team will help fulfill supply requests, assisting with supply delivery and medication obtainment. Operations will oversee the epidemiological operations at the county level and ensure that adequate contact tracing is occurring. Next. Now that we've discussed how we do the activation, I'm going to describe to you how we manage the response. Next. As cases are identified and partners and social contacts within the sexual network are tested and interviewed, a clearer picture of risk factors or subpopulations may emerge. This will help target DIS field investigation, case management, and disease intervention services, as these are very critical pieces to responding to an STD situation and ensuring things that go smoothly. DIS are able to effectively target areas where the situation is occurring and can give insight to leadership about where testing and treatment need to occur if they are not already occurring in that area. DIS will collect information by interviewing patients about their sexual partners or social contacts to help define the sexual networks being affected by the STD situation. This will greatly increase the ability to control the situation and the stop to transmission once we understand who the STD situation is affecting. The STD epidemiologist will be monitoring for new trends in special populations daily during response management. Next. As I mentioned before, DIS field investigations are one of the most critical pieces to response management. We have developed a specialized interview questionnaire that will adequately capture data needed to identify social networks and sexual networks. This, of course, is not an entire list of the questions available, but I wanted to highlight some of the questions that a DIS would ask. We would ask the partner, where did they travel for sex? When did they last have sex with people when they were traveling? When was the last time you had sex with commercial sex workers? Where do you have sex at? What type of gender or what type of sex are your sex partners? What type of sex do you have? When was the last time you had anonymous partners? When was the last time you used substances prior to or during sex? All of these questions help us develop an outlook of the situation and help us understand the people who are being affected and how we need to target our response efforts. Next. So now that we have determined some of the actions we're going to take during the response management portion, we're going to discuss on the kind of more administrative side, the meetings and reports and communications that need to occur to ensure that information sharing is happening. Daily response management meetings or as needed meetings can be held by both the state and the locality experiencing the STD situation. They will work together and agree to a schedule of meetings. The leader who has been chosen to oversee the response at the local level will give brief updates at these meetings. And additional tasks that could be covered at this meeting would include supply needs, staff needs, new trends, media development, or other collaborations or activities as needed. The STD prevention program staff themselves will hold additional daily or as needed meetings to provide general case updates and evolving epidemiological information. Situation or SIT reports will be crafted and sent to all leadership as necessary so that everyone is aware of the changes in case updates or new epidemiological information. Next. Messaging during the response will be determined by the Office of Public Affairs here at ISDH or the OPA. OPA will use information that has been presented at the response management meetings to determine what facts surrounding the infection need to be said to the public. OPA and the STD prevention program will work together to create appropriate messaging, and the STD director and the state health commissioner will approve this messaging before it is given to the public. OPA and the STD prevention program will work together with the local communication liaison to ensure appropriate messaging is being used across the board. Here in Indiana, we also have a few other options that would allow us to easily share information or updates about the STD situation. We have the Indiana Health Alert Network, or the IHON, which will reach local providers. We also have local listservs, so many clinicians have local listservs of other clinicians in their immediate area or surrounding area, and we would utilize these in order to inform the appropriate people about what is occurring. Next. So media requests will be another big thing during an STD situation. We want to ensure that truthful and standardized messaging is being used at all times. Media requests at the state or county level regarding the preparedness plan, its activation, or the response management should be directed to OPA and the JIC. The county level or local level communication liaison will also need to be informed, and we require that truthful messaging is given to the public in order to eliminate chances of panic. Staff who are participating in response management or any portion of the preparedness plan should refrain from directly communicating to the public and should refrain from any direct reports or any requests for comment or information and should take these directly to the state and county leadership. This includes social media because we want to avoid incorrect information being given to the public. Staff should also avoid using sensationalized lingo of infection, populations at risk, and body parts in order to reduce and eliminate stigma. Next.
All right. Now that Emily has covered activation and response management, now we're going to talk about recovery after the response. Next. Okay. So the STD epidemiologist will calculate a new endemic level in the counties and STD districts to begin the resolution and recovery process. This must be done prior to the declaration of resolution. Old endemic levels will not represent the increase of disease. New endemic levels will not be any less than old endemic levels. New standard deviations will be calculated also. This is done because it is difficult to declare a resolution with STD infection due to the fluctuating nature of incubation periods, the asymptomatic nature of infection, and the fact that the source likely cannot be eliminated. Next. The STD prevention program has established a general criteria to assist with declaring a resolution. For primary and secondary syphilis, the incident rate has reached the newly established baseline monthly incident rate minus 2 times the new standard deviation for a period of 6 consecutive months, or 2 maximum incubation periods of primary syphilis. For gonorrhea or for chlamydia and gonorrhea cases, the incident rate has reached the newly established baseline monthly incident rate minus 2 times the new standard deviation for a period of 20 days, or 2 maximum incubation periods. A debriefing meeting will be held by the state and county incident command teams within 7 days of the completion of the response in order to review information such as the number of contacts and clusters identified, interview and treated, number of new cases identified as a result of the response, and or barriers to future activations and responses. All right, next slide. And that is all that we have for you today.
Wonderful. Thanks again to Emily, Jeremy, and Madison. At this time, we will be taking questions. So if you have a question, please remember to select all panelists so we can all view your question. We do already have a few questions that have come in, so I'll start with those. How does a patient having state insurance affect eligibility, or if a patient is over the age of 30 but has insurance like Hoosier Healthwise, MDWise, or HIP?
Okay, yeah, so as far as eligibility for screening, state insurance. With state insurance, that, especially with Medicaid or HIP, that should cover STD screening. So they should be able to go to their provider and receive these services with no issue. If they are finding a barrier, then it could be reasonable to reach out to a CTGC screening site to talk with them if they are having some sort of barrier.
Thank you. Our next question, the different GC-CT collection tubes are different than what we were taught. We use a multi-test swab, orange stick, to do the vaginal and anal swab. We were told that the unisex swab was just for endocervical specimens and male urethral specimens, not for anal testing. Any comments on that?
We wanted to mention that the collection tubes that were pictured in our presentation today are actually for the long slender containers or for blood collection. So the participant is correct. Those are different than CTGC mailing containers. Those are short, squat, round cylindrical containers. The ones that we have pictured were specifically for blood collection. We unfortunately couldn't find a picture that specified the CTGC container, but those slender containers would be used for blood collection. So the participant is also right that the orange swab is a multi-test swab, so that means it can do vaginal and pharyngeal swabs. We use the orange swab only for vaginal. At this time, ISDH Labs is not able to do pharyngeal testing. The unisex swab we use for rectal samples. And if the participant has further questions about how to use the rectal sample unisex swab, Jeremy Musko will be available through email or phone call to address that participant directly, so we can see where some misunderstanding or miscommunication may have occurred when that participant was learning about the swabs.
Great, thanks, Emily. Our next question, who can determine if a patient is underinsured? Is the testing site able to determine that based on patient knowledge? We have students with international insurance that doesn't really cover anything other than emergencies, for an example.
So the sites would just need to talk to the patient and ask them whether or not they're underinsured. If the patient reports being underinsured, then the patient foreseeably is underinsured. As far as students with international insurance, that would definitely be underinsured. They have insurance, but due to this reason, they're not able to seek this service and have it covered somewhere else. So that would be correct.
Thank you. Our next question, what is considered high for high deductible and high copay?
So again, it would be the patient reporting that they are unable to receive the service somewhere else. So if the patient reports being underinsured, then the site would be then the patient would be eligible.
Really, there's no number amount at this time. We have not determined as a program an exact number amount. We rely heavily on patient report about what they are able to financially afford or not afford in regards to their insurance. So if the patient reports that their deductible or their copay is too high for their current financial situation, we attempt to service them with the CT2C screening program because they are getting these services that they obviously need but are unable to get in a traditional setting. So it's very situational based, and it relies heavily on the patient reporting back to you.
Thank you. Our next question is about the slides. These slides will be available to print and sent to you via email with the evaluation after this event. And with that, I do not have any more questions. Presenters, do you have anything to add?
We sincerely thank everybody for their time and attention today. We've thoroughly enjoyed educating you all on our comprehensive preparedness plan. If you have any additional questions about the preparedness plan or how it's activated or how your locality may participate in a preparedness plan, please feel free to reach out to us at std@isdh.in.gov, and we will be happy to field any questions or concerns everybody may have. We also do have a slightly updated PowerPoint to send out, so HCET will ensure that all participants get our updated PowerPoint that has just a few more information tidbits that we verbally said today, but we will have them available in print.
Wonderful. Thanks again to Emily, Jeremy, and Madison, and thank you everyone for attending. Like I said, there will be an evaluation sent out to you via email, and we greatly appreciate your feedback. Everyone have a great day. Thank you.